Adaptation. We talked about adaptation. I bet you guys got a good illustration of it during the lab. Did you? So, the smell seemed to be a rapid adapter for you guys? Yes or no? Yes. Okay. How about the, did you guys notice any kind of pain or anything like that? I'm asking. I don't think you guys hurt each other. I hope you didn't hurt each other. But that would be a slow adapter. Okay, but remember, we did talk about it as far as pain as a slow adapter. Do you guys recognize that? Yes, maybe?
When it says body position, does it mean like proprioception or does it mean?
Yeah, proprioception. Okay. Does that make sense? Let's make sure everybody's here that was here earlier, right? Except for Angela. Oh, there you are. There you are.
No, Amanda.
Amanda. That's why I'm just thinking out loud, that's all. I'm trying to see who did I not see or that I do see. I know, right there, it's like anything straight on your face and you don't even notice. So anyway, I'm sorry about that.
It's okay.
Okay, questions about that slide? Okay, so we're going to talk about somatic sensations. Remember what somatic sensations are? What are they? Skin. What's that?
They're more general.
More general. Good. Okay, so most of it we see in the skin. So guess what? We're also going to see some illustrations in the skin of the different types of receptors that we do see in the skin that are related to it. And like it was said, mostly general types of receptors.
And
So-
that's all over the body? Like
All over the body.
temperature, pain, touch, pressure?
Yes.
Okay.
Do you feel pain ever? Okay. I'll give you an illustration so you guys understand this. Today I went to a podiatrist. You guys may not have realized I sit a lot lately. Did you notice that? Yes or no?
Nope.
No. Chris, you didn't notice it? When
I
I'm
did
doing
not
the
notice.
PowerPoint, I'm sitting all the time with it?
More so than usual?
More so than usual?
Sorry.
Last week? Yeah, last week.
Last week I did. I have a plantar wart on my heel,
Ooh.
right in the middle of the heel. Not at the edge, on the middle. It's been bothering me for months. And it's been getting worse. So
Oh, no.
I've been trying to do it without help, and I went for help on it, so.
Did they give you the acid?
They gave me salicylic acid, 17%, and they also gave me a nice scraping, and told me I should scrape it even if it bleeds.
I work at a podiatrist office, so that's where it is.
Yeah. So, yeah, that's, and it was painful in certain parts of the scraping.
They didn't offer to know you?
No. The other option was,
The needle was, less pain, less people.
yeah. So, anyway, so I have to go back in 2 weeks to find out what's going on. And see what's good about that, okay? So, I've been walking on one toe and one foot regularly. So, that's why I'm still wearing boots, even this nice warm weather, because they give me more support. Okay.
I just thought you knew you looked good in them, that's all.
What's that?
I just thought you knew you looked good in them.
Well, I do, but still in all, I mean, it's also a matter that it gives me a little bit more support when I'm walking on a toe, okay, as opposed to, otherwise. Regular shoes, they seem to not give that support. So, one of the aspects of, when we're looking at somatic senses is tactile. Guess what tactile is? Touch, yes, touch. This is where we actually get pressure and vibration and tickle and such. Now, what I do want you to realize is we do have a couple types of receptors. So up on this board, you actually see Meissner's corpuscles, which is for touch. We have root plexus, which is basically a nerve that surrounds the hair root and the shaft that's in the dermis of the skin. We have type 1, which are Merkel disc, type 2, which is cutaneous disc or Ruffini's corpuscles. We have mechanical receptors. We have laminated, or what's known as Purkinje's corpuscles. And we have free nerve endings. All those are basically tactile. Now, some of them, if you're looking at like Purkinje's, is more of a pressure, a deep pressure, as opposed to, let's say, a hair root plexus, which is maybe a little bit lighter touch. You know, you might think about this if you were actually in your convertible driving down, wherever you're driving down, playing Shaka Khan with the air going through the breeze and the hair, feeling it. Who knows?
Shaka Khan.
Yeah, Shaka Khan. Ever listen to Shaka Khan? So, you have all kinds of receptors that are there.
What's the distinction between type 1 and type 2?
Type 1 and type 2 is basically whether or not they are more of a myelinated or unmyelinated.
Which is which?
Type 1 would be more of a myelinated, where you may notice it more. Type 2 may not be as much. So what are we looking at when we're looking at touch? You have crude touch and you have discriminative touch, fine touch. Did you guys feel the pennies? Yes or no? Did you get a chance to? Yes or no?
No.
The slide you just had on, after the mechanical
There you go.
receptors, then laminated,
This one.
okay.
Laminated, which is basically a Purkinje's corpuscle. Like I said, that's more for deep pressure. Okay. So what are we looking at? We're looking at the skin. Let's see if I can actually draw a skin where you guys can see. You guys might notice the skin looks something like this. You guys think like hair follicle. This is a very bad diagram of a hair follicle with the shaft. It actually has the possibility of muscle, right? You guys remember anything like this? Diagrammatically, let's see if I can run some other nice, lovely things in there. You might see blood vessels that are going in here, and here. You might see, let's see, Purkinje, which maybe look more like this. You might see free nerve endings coming like this. You might have some that are going also here. Okay. So we have quite a few different things that can happen, and that's before we actually get to the dermis, and subcutaneous layer. Okay. Does that make sense? Does that look like a very rough skin diagram? Try and draw it very quickly so you guys actually have a refresher on it as far as what may be there. So when we're looking at touch, touch can be crude and it can be discriminative, which is basically, it's discriminative is fine touch. I asked if you guys touch the pennies. Yes or no? It's okay if you didn't. What's that?
I've touched them before, but I didn't touch them.
You didn't touch them today, okay, all right. What's that?
I touched it today.
You touched it today, okay, that's fine. And I want you to think about this, and I mentioned it last week. I didn't locate my handy dandy little bag of coins or things that are in it to actually get you guys to think about it, of what you're feeling, okay, when you touch it. Okay. Because it does give you an illustration, because if you're feeling into your pocket, you may feel something, and you may actually identify what you're actually touching without, looking. That's discriminative touch. But it also ties in with that 2-point touch aspect that we're learning about, where you actually touched your partner and checked the distances. Remember, in certain parts of the body, like your fingers, your hands, they actually have a closer distance as far as discerning different things, as opposed to, let's say, other parts of the body where maybe a larger distance, okay, because you don't have as many receptors. But crude touch is basically you feel something. I'm leaning on this table. I feel something on my hand. What it is, I don't know. It could be a table. It could be this nice wall I'm holding up. Okay? It could be something else. So I want you to realize, crude touch is where we feel something, but we're not really sure what it is. Discriminative touch, we can actually distinguish details. Okay? That's why when I asked about the penny, it helps as far as understanding. If you look at your phone, difference. You feel the phone in your hand. But the phone, if we actually give it as an analogy, the phone will distinguish where you placed your finger on this keypad to actually distinguish what you're trying to do. Whatever that may mean, whether it's pressing in your passcode or trying to, touch on some sort of app, whatever that may be. So discriminative touch is basically where we see shapes and sizes and textures and things that are more clear cut. I mean, I can actually go into my pocket and I can feel, without looking, this is a pen. This is a highlighter. This is another pen. This is a piece of paper. And I'm just demonstrating that to give you an idea of what discriminative touch is. It's not really rocket science, but it does give you a key to understanding what discriminative touch actually is. Was I right? But you can also go into your pocket and feel for change when you're going in the store and trying to figure out, and of course I don't have any change in my pocket, I have just these things in my pocket. So that's not gonna really help you guys. Flash drives. Got a switchblade one. Dangerous. Flash drive. So I want you to realize that basically it's to understand a lot of this. But you have different receptors. These receptors, a lot of times when we're dealing with touch, can include your shared mentioned the whole idea of shop behind the breeze, but you could actually be right on the beach, feeling the breeze coming over you as you're sitting there in the sun, and the breeze just comes by, and it feels so relaxing, or not, depending on the situation. It could be a hurricane breeze, that would be more intense. But I want you to realize that when we're looking at it, we're looking at the different receptors that are actually able to detect that sensation. When we do look at Meissner's corpuscles and the hair plexus, this is where we actually have a rapid adapting. Okay? We feel it, we don't feel it. Okay? As opposed to slow adapting things of for touch, which would be more of the Merkle disc and the Ruffini's, which may be a little bit more intense than just a light breeze. We do also have pressure and vibration. Pressure and vibration. What is pressure? Pressure is where we feel, a little bit more sustained sensation. Anybody ever, and I used my bag as an example last week, but if you felt that bag, and you guys actually have books, and you have computers, and you have things that you carry around with you, you may actually notice the pressure as you're carrying it. And it's long lasting. This is where your deeper pressure, like Percinians, will actually be more noticed as far as that pressure. So you actually identify with it, the intensity of it. Okay. And sometimes it adapts rapidly so you don't notice it over time. Anybody can pickpocket it? Yes or no? I remember in Barcelona, I got pickpocketed. What they pickpocketed though, and I never even noticed it was in the subway, was the map of the city. They thought they were grabbing something else. And I never even realized it until afterwards. So, when you're pickpocketed, it actually plays on this whole idea. Because you have that rapid adaptation of the pressure. This is why a lot of times what they do is they basically take something that you think may have more value. Like if you're carrying a wallet, they usually identify where is the typical wallet, at least on a gentleman. Okay? In the pocket. Which pocket do you usually use? Chris, where do you put your wallet?
Front pocket.
Front pocket, okay?
Yep.
Mike, where do you usually put your pocket?
Left pocket.
Which one?
Left pocket.
Front or back?
Side.
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 Oh. Put it on the side or back?
No, I usually put it in like one of my side pockets here.
Okay. How about Bendel? In the front. Most pickpocketers don't think you're going to put it in your front pocket.
That's why I put it in the front.
I always put it in my front pocket. I used to have it in the back pocket, but I think most men put it in their back pocket, not realizing that it's so much easier for somebody to just release.
Okay.
Just like I'm going to say to you, ladies, where do you put your wallet typically? In your purse. And where do they grab for it? The purse.
That's why you gotta wear crossbodies.
Well, Yeah, I understand, and that's why I want you guys to be aware that typically that's what they're playing on, okay? Because the pressure is there, okay? That you have that, you know, weight, that sensation, but you don't notice it because, well,
Don't they also like replace the pressures of those?
Oh, yeah, they do.
So I mean, it mimics the same
Yes.
pressures that you're already used to.
yeah. And they also use diversion techniques. You know, if you see, and I've seen it in movies, I haven't seen it, you know, I can't detect it otherwise, because otherwise I would have noticed them lifting the wall, you know, the map. That the bump and grab is one of their techniques.
The
you know,
distraction.
the distraction. Okay, so, but this is where we actually see that issue. Okay? Vibrations, on the other hand, this is where you have sensations and it actually goes away, comes back, goes away, comes back, goes away, comes back. So it's intervals. But it helps you to identify what's going on. This is usually, like for instance, do you guys notice vibrations in this room? Yes or no?
Yeah.
I think it's fine.
Yeah, it's vibrating, but I can actually feel the floor a little bit vibrating.
Yep.
But you have to think about it, don't you? You know, you don't always notice it, because we're thinking about other things. But this is actually where we actually see the vibrations can also be a tactile sense. And it does happen, where we actually can feel it. But we don't, because we're not used to, you know, we don't put our minds towards it. Which gets us to itch and tickle. Tickle are basically you're actually looking at two things that are exactly the same, but the difference is, one's actually a sensation where you have vibrations that are there, and it's bothering you. The other one, somebody's providing it to you. Anybody ever get tickled? Probably most of us have at some point in
Yeah.
time. I'm not saying when or how or anything like that, but I do want you to realize when you get tickled, somebody else is tickling you.
Yeah, I heard that. You can't tickle yourself. Why is that?
No, because you're anticipating it,
Oh.
Chris. Whereas itch, when you're itching, it's the same type of sensation. It's the same exact sensation of the vibrations of what's going on with the tactile sense.
So what does it mean when you like overload your sensors? Like when you scratch an itch and that makes it go away, but in a way you're kind of overloading the sensors. Can it just not process the amount of
It's
information?
basically where you're actually causing your receptors to be basically just having signals that are just too many. And your body, and your basically your integrative center, whether it's the spinal cord or the brain, is then at that point not able to really discern what's going on. It's just overloaded with information. So when you actually notice that you get tickled, somebody tickled you, or something tickled you, whereas itch, it's something, if you were tickling yourself, you would actually get an itch from it, basically. Okay? But it's pre-nerve endings where this is happening. Questions? Okay, we're gonna see their diagrams of the skin next, just so you guys know. We'll compare and contrast my drawing from theirs, how's that? There it is, there's theirs, there's mine. Which one do you think is, took longer to draw? Which one? Do you see any real difference as far as the concept?
You drew that one?
Which one? That one. You missed
Oh.
that, Chris? Did you miss that, Chris?
I did.
Oh my
As
goodness.
a matter of fact, I did entirely.
How'd that happen?
So much.
Wow.
I'm focusing on the
how fast did I
test.
draw that? I must have been instantaneous, right?
Like you got me stressing on a test on Wednesday, man. I'm like trying to do two things at once.
Okay, so basically you'll see on here, you have free nerve endings right up here, okay? Which is similar to what I drew up there, right? You have a Mycenians corpuscle up here. You have Merkel disc up here. You have a Ruffini's over here. You have the hair plexus right here around the hair follicle and the hair shaft. And then down here where we have this large structure right below, right above the subcutaneous layer, you actually have the Persinians corpuscle. Now, notice Persinians actually has a lot more connective tissue around it. Okay, that's why it's more pressure. Okay. So when we're looking at it, basically, just like we had, we always notice that the nerve endings and all are in the dermis. That's where you actually see it. We don't have the epidermis. It's at the edge of it, even though we usually think of it being in the epidermis. But what do we actually see? Well, basically, we have Meissner's corpuscle. It's basically very good at discriminative touch and vibrations. It has a rapid adaptation, and it actually is the main onset when we're feeling something touching us. Okay. The hair root plexus is where we have free nerve endings, and it detects movements in the hair. This is why I use the breeze or the wind to actually help us indicate that. Merkel's disc, this is flattened out. It is 25% of the receptors in your hand for discriminative touch. Ruffini's, these are deeper in the dermis, and it's for detecting heavy touch, continuous touch, and pressure. Ruffini's. Excuse me, not Ruffini's,
Merkel disc.
And the Persinian corpuscle is where we have a good amount of encapsulation. It's deeper in the dermis, and it actually is for pressure and am I going to ask you about all those? No, I will not. Okay? So I want you to realize we're going over it even though I'm not going to ask you. Okay? But it does give you insight of understanding of why certain things work the way they do with the body for perception. So when we look at it, touch is basically crude or discriminative. I'm going to try to find my little bag which has the touch and feel to see how you get a demonstration of discriminative touch. Okay? I'll try. I hope I can come by tomorrow. Okay? For you guys. All right? Pressure is sustained over an area. Vibrations are basically repeating signals. Itch and touch basically are free nerve endings, but itch is basically getting sensation, whereas tickle you are having somebody stimulating it. Now, It says chemical. One of the things I want you to realize with the itch, you do get chemical, but what is chemical, basically? A lot of times it could be related to the changes to the skin. Anybody ever have, and I'm gonna ask this question so that you guys can think about it. Anybody ever experience eczema? Okay. What's happening? Well, basically, you're having a change, chemical change to the skin, which is then causing that irritation, that itch. My one daughter has severe eczema. And when I say severe eczema, she basically, as a very little child, she had it even on her eyelids. I know. Yeah. And with her, I know that stress or things like that, nervousness, actually stimulates these flare-ups.
It's like so itchy that even trying to sleep.
She's used all kinds of things. She's been on steroid creams and things like that. Currently, she's actually on an injectable.
Does it help her?
Yeah, it does help her somewhat.
It was good for it. Eczema psoriasis, it's expensive, but it works. Goat's milk.
Goat's milk.
It's like $30 a gallon, but it works.
Okay. I know we've used oatmeal baths and things like that, but she's on Dixie right now.
I've got great. Mine are on my hands, so.
Yeah, she gets it.
Never mind, yeah.
So she gets it very bad.
Yeah, so like, I'll wear gloves to sleep, because otherwise I'll scratch through my hands during my sleep.
Yeah, so she, it's very unfortunate.
Itch is like the worst sensation there ever is.
Yeah, and unfortunately in school, when she was growing up, children are not always
Nice.
polite,
Yeah.
nice, and teachers sometimes don't comprehend that it's non-communicable. Okay. That's, you know,
They think it's a rash or something.
yeah, they think it's something that can be transferred. So, anyway. So do you guys follow that?
So when someone is like more ticklish than someone else, I guess that's just like their free nerve endings are just more responsive, or?
Yeah, and a lot of times you may notice, here's another thought, tickle. And I'm not gonna ask the question to give an answer for it. I'm asking it more as a rhetorical question. Do you typically notice tickling occurring at a specific location on the body or body parts? I didn't say yet you had to answer. It was rhetorical, okay? But I want you to realize that a lot of it is based upon those nerve endings, where they are, where they have a higher amount that may then have more of a susceptibility for it. So I'm trying to let you guys know that I understand that it does happen in certain parts of the body more so than others. And this is one of the things that if you're looking at it, that's why during the lab, I let you guys, explore what the different things were as far as testing with the nerves, because a lot of times that helps you to understand better. Okay? Did anybody do the Babinski?
Yeah, no, I know my husband, he's like, "Well,
Okay, you did it at home, that's fine, I just want but you see what I'm saying, this does give a good indication of different things, because when you're testing it, in a controlled setting like we are using here, if you make an error, you make an error, you do it on a patient, it's a little bit more difficult, because if you did it correctly or incorrectly, it may get different results. Okay, so you want to actually have that inside. Okay, any questions about somatic tactile? Okay, let's look at thermal. Here's the interesting thing. Thermal are also free nerve endings. They're in the skin. You'll notice you have a typical range of 50 to 105 degrees for cold, and for warm, 90 to 118 degrees. And that's in Fahrenheit, by the way. Both will adapt rapidly, and they will, you know, have a low frequency. And think about it, if you actually, you know, go into a warm environment or a cold environment, you'll notice it more so, where it adapts. Anybody ever do the polar bear swim? You guys know what that is?
Yeah, January 1st.
Yeah, but you know, I remember going to camp, and they did polar bear swims in the morning, like 6 a.m., 5 a.m. in the lake. You know, lake water is like, it's cold in general. Yeah, not my cup of tea either, Michael. I think when I see the people that do the polar bear swim on 1st of January, I think about it and I say, gee, that's you know, it must be you know, something going on up there that's not completely the way I would think.
Do they do it for charity or they just do it?
They do it for fun. They enjoy that apparently. But why? Who wants to go into, you know, almost freezing water in the middle of, you know, in the 1st of January? You know, I understand they get the cameras on them and they're, you know, get notoriety for 2 minutes on the news. But, you know, is it worth that? No. And plus, for me, the worst part is once you get out of the water. You may adapt to the water, but then you guys know what it's even like if you go down to the beach, you get out of the water, and if the temperature on the, you know, outside the water is not completely 90 degrees, it feels sometimes cold. Now, here's an interesting thing, which it doesn't say there, but this is important for you to conceptualize. 20 degrees difference than what you're used to. You've adapted to this temperature, whatever this is, in this room. You get a 20-degree difference, hotter or colder. And what do you say? You're noticing that difference, and that's when you actually identify that there's a real difference in the temperature. And if you got used to this temperature and it goes up 20 degrees, it's roasting. It goes down 20 degrees, you're freezing. And I want you to realize that basically it's a very small margin where it actually changes, but you do adapt to whatever is occurring at that moment. Okay? Which is one of the reasons that if you actually get into, let's say, I mean, I went swimming over the weekend. Was it this weekend or last week? I don't remember. It was, I think it was on Memorial Day weekend. Was that last weekend, right? Not this past weekend. 2 weeks ago, yeah. You know, the temperature was around, what, 80 something? The water was whatever it was. I felt cold getting in the water until I got in the water, but as soon as you get out, it's cold. But you get used to it, you adapt. You adapt to that temperature while you're in the water, as long as you're moving around. You guys know what I mean by that. But then, if the temperature changes, you get out of the water, you feel the breeze, it feels much colder than, because it actually is, the water is a very good heat sink, where it actually drains the temperature. It goes from where it is hotter to a cooler location. You'll notice that. So when we actually noticed it was hot in this room, I'll open the door and the hot goes out like crazy. Whereas cold, it's not always identifiable, okay? But it still has that transfer. And water is one of those quick transference locating things of temperature changes. So I want you to realize that it does actually notice it. Pain can also be identified at below 50 degrees and over 118 degrees. So when you're actually noticing it, that there's extremes, you can also get pain associated with temperature changes. Anybody ever notice that? Okay. Any questions about thermal?
So if you're sensitive to the cold, and it just mean that receptor is more susceptible?
Sometimes, but also it may depend on some other factors, like we talked about, the sympathetic nervous system being overactive. That may be another factor. Okay. All right. So that's variations in divisions. Yeah. Here's a thought. Remember I talked about cooking lobster? If you put lobster in a temperate water and heat it up, it's going to not notice the change in the temperature. And it may not cook as well, just so you have an idea of cooking. Whereas you put it into boiling hot water, it notices right away, but then it cooks pretty well. Lobster. You guys like lobster? Okay. Okay, pain. You guys like pain? Sometimes. Sometimes. Who likes
Certain
pain?
times. Certain times.
Who likes pain? Who said that they like pain? Was it you, Monica? Okay, I just want to make sure I had a perception of who was into pain. No, I'm just kidding. But I do want you to realize pain
Depends
is
on what
very
it is.
good to have. It is it is nickel receptors, basically identifying damage. Okay, and it's identifying it on free nerve endings. It identifies when there's cellular damage and when there's tissue damage, which is important. Because if there's damage, that means something's not working correctly. And even if we don't enjoy pain, I'll say it that way, Monica, we do like the idea that when we do have something wrong, that we do actually experience pain, because pain helps us to then react to it or do something about it to try to find out what's going on. I do want you to realize pain is found in all parts of the body. Okay, we do adapt to it slightly, and I want you to realize if you ever had a toothache, if you ever have other pain, you realize that it doesn't want to go away. It's persistent. It wants to stay there. Okay, until we do something, get it corrected or whatever needs to be done. A lot of times, it can be related to also muscle spasms. Anybody ever have tension headache?
Yeah.
At times? Looks like Chris is ready to have one. He's doing one.
Just about there. Give me a second. Let me experience it.
Yeah, okay. This is one of the things that
is really where they may actually have stimulation of the muscles and they contract and they don't relax, and then what happens is it actually causes you to actually experience some sort of pain. Remember, typically a headache, tension headache, what is it? You think of it as a headache, but it's not really a headache because it's not in your head. Well, it is in your head mentally, your perception of it. But the pain is not existing in your head. It's occurring mostly in muscles that are strained.
Not in the brain.
Yes,
Not
the
in the
brain is identifying it,
Okay.
but it's not where the pain is experiencing. It's where the muscles are actually tense, and that tension is then getting that perception. Does that make sense? So when we're looking at it, that's why, muscle spasms can be related. Blood pressure, flow of blood pressure can also create that. We talked about different things, with blood flow. And I want you to realize that sometimes it may not just be the blood flow, it may be what is needed. For instance, you get, let's see, who was it that said they like to drink a lot? Oh yeah, Chris, right? No.
I
When
plead the
you
fifth
do,
with Jack.
what's that?
I say I plead the fifth with Jack.
Okay. You like to have your partners, Jack and Jim, to worry about, right? But in all reality, what do we actually experience when people do consume alcohol? A lot of times they actually experience where they have dehydrated, and that's also playing a role with the blood flow. And it may be related to glucose, it may be related to the electrolytes, and that's where we actually also experience changes. Now, what can we actually notice? Well, when we have damage, a lot of times we release more potassium ions. We actually have kinins and prostaglandins. Prostaglandins are one of those chemicals that our body releases as far as when there's damage. And typically, that then stimulates the nicoreceptors, the pain receptors, those nerve endings that are identifying pain. Okay? So, what can we do? Well, keep in mind you do have different types of pain. You have acute pain, that does not mean it's cute. Acute pain means it's fast onset. And we have slow pain, which is more chronic pain, where it actually lasts and lasts and lasts. Acute pain, which is fast pain, basically is things where you might notice it and it goes away like this. You guys have experienced having an injectable, having your blood drawn. This is acute pain. Okay?
What classifies chronic?
Chronic, it lasts. It
Like-
stays there.
Like a burn?
Like a burn,
Would that be
like a toothache,
Back pain.
back pain.
What about when it comes in increments, like when you have repeating episodes of certain spasms or pain sensors?
Well,
Isn't that chronic?
it's chronic.
So, like, how is that defined? Or does it's just all chronic?
It's chronic
Just-
because it doesn't really go away.
Okay.
All right, it's not where it's a short-lived pain. Okay, acute pain is short-lived. Okay, so that's the main difference. Yes, there are differences as far as the nerve fibers that are existing for them, but that's about it. Chronic pain can also be deeper. Okay, so that's where we actually notice it. It's usually more intense,
The chronic pain?
chronic pain, yeah. And I was trying to do steps.
get my crunches in.
Yeah, I can see that. So when we're looking at pain, pain can be actually superficial or it can be deeper, it can be more visceral. Superficial pain will actually affect the skin, the muscles, the joints. Deeper pain would be more of the tendons. Visceral pain may be in specific organs. We can get them localized, and we can also get them more generalized. So think of it this way. When we have a localized pain, it may only affect that one area. Okay? For instance, they mentioned distension of the ureter from a kidney stone. Anybody ever experienced a kidney stone?
Yeah.
Okay. But I would also say it could be, you know, if you actually had a blockage in your intestines. That would be more visceral pain. Or if you had appendicitis. A lot of times we actually still notice it at the surface of where the organ is. And this is where you might remember the dermatomes that actually gave referred pain. So we're going to see the referred pain diagram, which looks like this. Notice the red one associated with the heart on the left arm. Notice the yellow for the kidneys, if you have a kidney stone, the yellow. The lung and the diaphragm is green up here. The gallbladder and liver is right up here, here. And you do have certain locations where referred pain does occur. And there's a pattern that typically occurs for it.
So it's big, like dermatomes?
Yeah, it's, a lot of times dermatomes also is helpful in understanding this. Okay. So what do we do for pain? What do you guys do for pain?
Depends on the severity.
I hope none of you do the, what is it called? Hair of the dog? As a means of relieving that pain, you know?
Only if I have to get to work, you know, it's
Yeah.
don't have time.
Yeah, you know, the hair of the dog, if you have pain, you create more pain. I had an anesthesiologist that actually gave me anesthesia to actually to introduce the IV. He would actually give pain a little further up just to make it more painful, the catheter, so that it would not be noticed. Hair of the dog, pain.
It works.
More pain in a different location so you don't notice the pain that's.
Yeah, one pain's more bearable.
Like in the middle of the night, if you're walking around your room, you bump yourself and back in the bathroom.
Yeah.
It hurts, but then if you bump your knee,
You'll,
you'll feel the
that'll
knee
take
or
it
the
away.
Yeah.
itself. Okay.
Yeah.
Just
Yeah.
different localization. Something more bearable.
But we're not talking about that type of thing, okay? What we want to see is, what do you do? If you do aspirin or ibuprofen, it blocks the prostaglandins at the receptors. Okay, and remember, aspirin has been around for over a century now. But that's what it does. Okay. Novocaine will block the nerve for the pain fibers. Anybody ever use Novocaine?
Yes.
Yeah. Oh, yeah. And of course, there's other members that are similar to it, like lidocaine. That's more for skin topical type applications, as opposed to Novocaine, which would be more of a dental type thing. And you'll notice they use the Novocaine before they actually introduce the needle of the pain.
Morphine is also used, but that's actually lessening the perception to the brain. Morphine is what you use for chronic pain for a lot of patients.
That's what you just use, like, to keep them comfortable, like,
Yeah.
for the final days. No, they go in, that's stronger than morphine, right?
Yeah.
But does it have the same perception of pain in the brain that that one?
Not always. Okay. But morphine's also, I mean, it's used in a lot of cases. When I had the surgery, they gave me morphine. Yeah. Why is it, why is it not used much? Because it gets adaptations. Okay. And when they gave it to me, it was only for a very short time after surgery.
They just went straight to morphine, they didn't even look at blood.
No. Little shot.
Oh, yeah,
you know.
I mean, they still use it a lot,
Yeah.
just different percentages. They still use it a lot with pain management,
Morphine?
just different percentages.
Yeah, they try to stay away from it, though. Like, no,
Yeah.
no, sorry,
Okay.
Oh, we have a lot of post-surgeries that use it. Nope, morphine, a lot of morphine.
Proprioception, basically, one of the things that we do is we have it in the muscles, skeletal muscles and tendons, around joints. You guys actually did this as far as the board. Do you guys remember putting the images on the board, the cross, and you try to identify?
Yep.
Okay, proprioception, body structure, equilibrium, that kind of stuff. So a lot of times what we see is this is actually giving you the awareness of your body. Position, movement, things like that. Like Karen was just talking about, walking around in the middle of the night. You know you're walking, things like that. So, and you have an identification. You know, things like, for instance, how much something may weigh that you're actually adjusting towards. Like when I carry my bag, as opposed to when I'm not carrying my bag, I adjust my equilibrium based on that. I don't know if I fall over on the side. Okay? Because of proprioception adapts slightly, but your sensors, basically your sensors will send messages to the cerebellum and the cerebrum, and they adjust the muscles accordingly to compensate.